So without further ado, thank you very much to our special guest presenters today. So Professor Sandy Middleton and Mr. Suchit Handa. So Sandy is the Director of Nursing Research Institutes at Vincent's Hospital and the Australian Catholic University and Director of the SPHERE Implementation Science Platform. She has researched clinical registry participation nationally and internationally and currently chairs the Australian Stroke Clinical Registry Steering Committee. She also chairs the Australian Commission on Safety and Quality in Healthcare Clinical Quality Registries Framework Review Advisory Group. So it's going to be great to have Sandy, and she is going to speak to us first up. And I'd tell you her topic, but it's not showing on my screen. So our second speaker, Suchit Handa, is Director of Safety and Quality Improvement Systems at the Australian Commission on Safety and Quality in Healthcare. And his directorate leads projects to support the meaningful use of indicators, analysis and data, including clinical quality registries. These projects aim to support the feedback of safety and quality data to multiple levels on the health system, including consumers, clinicians, administrators and funders. And the Commission has developed key documents regarding the governance, operation and technical requirements of clinical quality registries. Now, I'm going to close my PowerPoint. I'll stop the share. I'm also going to hit record in a minute. And Sandy, if I could hand over to you. Thank you.
Thank you very much, Marilee, and for this lovely invitation to speak with your group today. I'm very delighted to be here. Before I start, I'd like to acknowledge the traditional owners of the land on which we're all meeting today and to pay my respects to elders past, present and emerging. So today I'm going to talk to you about clinical registry participation and is it influencing the quality improvement activities. I'm going to give you a couple of examples of work that I have done and also just talk a little bit about the Australian Stroke Clinical Registry and how we manage research participation. So I have these disclosures. I felt like I was very American and having to put these up last night. I thought these are actually quite important, and I very rarely have a disclosure slide, but because it's very important that I have several hats at the moment, I really wanted to put this on, and I'm actually speaking on behalf of myself as an individual rather than in these capacities. So what we do know is that data are being collected across multiple specialty areas, but we really still don't know who are contributing data to clinical registries and whether data from registries are being used to drive local clinical quality improvement initiatives. We've got a much better idea about who are contributing data to clinical registries. It's getting better, but when we first started this first study about this, there was no central list. The Commission hadn't done their database of listing all the clinical quality registries across Australia, and it was actually really difficult to find that out. And people said, oh, just go to the Director of Clinical Governance at the hospitals, they'll know, or they didn't know, or we'll just go to the ethics committees. Again, they didn't know, and as you know, not all registries go to get HREC approval. So it was quite cloudy and quite difficult to find when we did this first study, but as I said, things have improved since then. But what we also don't know is really about staff knowledge of implementation science methods, and that's really the science around changing practice behaviour and what training clinicians need to improve the use of their data to drive clinical practice. So what we do know from an economic evaluation done by the Commission back in November 2016 is that there are significant positive returns on investments and positive benefits in terms of cost ratio benefits for registry participation. And the benefits reflect improvements to clinical practice and also outcomes over time. And the conclusion from this review that the Commission did of 5 clinical quality registries is that registries are significant value for money, particularly when they're correctly implemented and sufficiently mature. So what we wanted to do, the other thing is too, of course, the Commission has put in their national standards some really important standards around the importance of monitoring variation. And it clearly says in these standards that health services must monitor variation in health practices. And that includes feeding back to clinicians, reviewing their performance, and supporting clinicians to review their practice and addressing unwanted variation. And I really love these standards, 1.28, when it came out in this document, because I'm thinking this is really great and it's going to promote better use of data, and also will support hospitals in terms of deciding whether registries are something that they should be participating in. So we aimed to identify what hospitals were actually participating in any clinical registries across SPHERE. And we wanted to ask and find out how the registry data are actually being used to influence local quality improvement activities. We also wanted to identify educational needs of the teams to actually improve the behaviour change and translation to actually drive practice change. So we had a cross-sectional self-administered survey across 7 hospitals across the 4 SPHERE local health districts. And it was conducted between November 2019 and March 2020. And we included all clinical quality registries, condition and disease registries, and also device and product registries. But we did exclude drug registries, limited time use, such as clinical trials and research studies, and clinical orders and point prevalence data collections. We had a very good response rate of 70%, and our results showed that of the hospitals, 97 hospitals who responded, 25 were contributing to state registries, 47 to national registries, and 21% to international registries. The majority of data were collected by nurses, and just over half were collected by a retrospective medical audit. So interestingly enough, very few of the registries were funded by state and federal government funding, and the most were funded by hospitals or self-funded by clinicians. And so I think that's interesting, and it'll be interesting over time to hope that this will change when perhaps more centralised funding comes through for registries. About 50% of the data of our registries were collecting patient outcome data, and that's something that we hope would also be wanting to change over within clinical quality registries, as patient-reported measures and patient outcomes are really an important part of registry participation. So who receives registry reports? Now we're getting down to the real nuts and bolts of it, because the reality is right down the bottom here. You can see that the LHD executive, under 10%, directors of clinical governance, under 10% of these executive people are actually getting registry reports. But even at the other end of the game, head of department, sort of over 35%, other staff, medical staff in the department, about 30%. So there's a lot of information that's being collected that doesn't seem to be getting back to the clinical front line and also to the executives. And I think that's really important and something that we really need to think about addressing. In terms of what reports were provided by registries, less than 50% of the registered clinicians who completed the survey had access to real-time reports. And I think that's a number that we'll see a change in going forward, because it's a lot of people now are developing dashboards and interactive dashboards, but you can see back in 2020, less than 50% had an interactive dashboard. I suspect that is largely unchanged, despite people's interest in this. But only around just over 50% were able to benchmark against peers. And that's really crucial for hospitals to work out how they're going and to actually work out, you know, where they fit within the state or national profile. Now, sadly, less than 50% reported regularly using the clinical data for quality improvement. And really that is the whole point of a clinical registry, that the data should be used for quality improvement. Quickly, in terms of training needs, over 75% reported quality improvement training would help to support practice change. And you can see these are some of the things that we suggested, and they were all very much supported. And there was a great interest around identifying the practice gap, interpreting the data and practice improvement methods. So the recommendations from that particular study showed that there was inconsistent, inadequate funding, and that's going to come as no surprise to many of you involved with registries. The visibility is poor, and we need better engagement with executive and governance units to make sure that registry data is incorporated into clinical practice. I mean, I would love to see, you know, we've got this board at our hospital where there's lots of information, a television screen when patients walk in. I would really love it if, you know, we were able to say, we participate in data collection for these number of registries. And because I'm hoping that we need to talk the language about the value of that, and for patients to understand how important registry participation is as well. We need to embed use of registry data for quality improvement, and that's a very well-known issue at the moment, and I know the registries are working very hard to address that. And there's some educational needs around making sure that the staff who are using the registry data or have access to it really understand what they can do with it and how to use it to support practice change. So this paper was published in 2021 in the International Journal for Quality in Healthcare. But then we went on to actually think, well, that's a picture, you know, for us across SPHERE, but what's the story internationally? And because I do a lot of work in stroke, we looked to see what the story was in a large international registry of stroke care quality, particularly based in Europe. And it's been going since 2016. So we ran a similar survey. This is a standardized registry across Europe, and it has dashboards and downloads with benchmarking at hospital national level. And again, we wanted to find out whether these rescue data were being used to inform local quality improvement activities in stroke and to identify educational needs. So the methods was the same. It was a cross-sectional self-administered survey of hospitals who were registered up to 2021 with rescue. We sent it out to the local hospital coordinators, and they participated in the survey. So who receives monthly feedback? And again, these results really do mirror our results across our SPHERE hospitals. That it's the medical staff in the unit and the head of the department who are getting them, but not reliably, less than 30%, and hospital administrators again around the 10% mark. So scarily familiar. I think there's a bit more positive effect, that positive feeling that participation has led to improvements in the quality of care, with strongly agree coming out at around over 70% of people using their data. So I think that's possibly that's a little bit better than the data that we had locally. And we asked them, do your data influence clinical practice always or often? And again, look, these are sitting around the 50 to 60 mark for some of these improvement, clearly can be made. So in conclusion, the registry data are valuable resources for hospitals to use in the quality of care and identifying areas for improvement. Education for staff in quality improvement science, I think, is probably needed to help them use the registry data to drive clinical practice change. So I think the takeaway message is we're not quite there yet, but the potential is huge. Some of this is going to come about with all of these other changes that are going around in registry land about funding and dashboards and making the data more available, making it instantly available rather than having to wait for a time to get local hospitals to get their data back. And I know that these are hot topics in registry land collectively. So I just want to spend a couple of minutes just talking to you about how we manage ethics in terms of the Australian Stroke Clinical Registry. If we want to add a new hospital to our registry, we write to the hospital lead HREC and ask to add on a site. And then we go and get the site-specific assessment back at the new hospital and submit the documents there. And then the site gets approved locally, and then we do the training that's provided, and the hospital's added to the OSCAR program. So that's pretty straightforward. We do have an opt-out approach, and this is a best practice for clinical quality registries. Not all registries have this approach, but it is in line with the National Statement on Ethical Conduct in Human Research in Chapter 2.3. We know that explicit consent on all patients is not feasible, yet we really need all patients to be in a register because that just makes the data more reliable and generalisable. It's very low risk and it's in public interest. And we do have mechanisms for people to receive information and to decline participation and also to keep their information secure. So people can opt out. Patients provide information and participation is presumed unless they take action to decline their involvement. So patients can also choose to have just their personal details removed if they opt out, or they can have all the details removed. And we've got a very pleasingly low opt-out rate at only 2.2%. We also have a waiver of consent for patients who die in hospital, who are documented in their medical record as being incapable of understanding written information, or who have no next of kin or responsible person who can actually receive the information. So I won't go through this, but we have a very, this is the opt-out process described in a flow chart. Really, I've just kind of walked you through, but there, as I said, there's opportunities for people to remove all or part of their information. So research is a really important element of clinical quality registers. And even though we are moving away from that paradigm that registries are all about research and their research tools, you know, that's very much a thinking in the past. We know that registries exist to drive quality improvement. However, research is an important element of clinical quality registries. And we have a very rigorous process for assessing whether research is of value and is something that the OSCA is prepared to support. So what happens is we have inquiries come in and they also tell us what they want to do, and they ask for a quote, and then they have some discussions around how much it would cost for the research to happen. And then if the estimate's accepted, then the applicant is responsible for going to the HREX to get their ethics. And once they have their ethical approval, so it gets for a separate, the research gets reviewed by full ethics committee. And then once that comes through, then they submit their application to us for our research group, our support group application with any of the HREC approvals. And it basically cascades through this. We have a research task group, and issues are flagged around this. The application has 2 independent reviewers to decide the worth of it. And then basically approval happens, but then it goes up to the management committee, and then it also goes to the steering committee. So there's quite a lot of checks and balances along the way. And then the principal investigator gets an approval letter. And the way that we manage this to keep all the data secure is that we never send data out to the investigators. They actually get access to the data, so they have to dial in to get access to the data that still stays on the OSCA on the server, which is a Monash University server, and they get secure online access. And they also, if they need, sometimes they get a bit of support about how the analysis might go if they come unstuck a bit. And then they have to acknowledge participation in OSCA in any manuscripts, and there's a 12-month final report. So we think that we, cover everything off quite in a very rigorous way, and the data are secure. So that is really the end of my presentation. I'm very happy to take questions.
I can't see anything in the chat. If anybody has a question for Sandy, feel free to just speak up, because there's too many of you on the screen for me to see you all. All right, we might we'll move on to Sandy. Thank you, Sandy. And I'd ask you to think about that. And while Suchit talks to us, you might find crossovers in there in terms of what he's saying with what Sandy's just outlined as well. We have, again, feel free to ask your questions at any time, put them in the chat. Oh, I have a question. Sorry, somebody's telling me. Pamela. Pamela, do you want to speak to
That would be easier. My typing's not that great.
it?
So, look, I'm interested, Sandy. Look, and I know that opt-out consent is an appropriate way to go with registries. But we've run into trouble at various stages where people have found themselves on a registry and contacted by, a state or federal department about further data and surveys, and they're very upset because they didn't even know that their data was in the registry. And certainly as an ethics committee, we often see this opt-out option tucked at the back of an information sheet and consent form, and it can be difficult for participants to access. And also when they've got a lot of other medical stuff going on, it's probably the last thing that you want to do is to call a 1-800 number. So from an HREC perspective, we find opt-out consent not so much challenging, but we need to be really sure that we cover off on it. Could you just speak to that and that process? Do you have any advice for us as a committee or for others who are involved in this sort of research? Look, I appreciate, Pamela, the concerns, which is exactly why we have ethics committees to really raise these important issues. We do make a lot of effort to inform the patients, and we've got posters around the participating hospitals, and I know it's all very well and good. They've still got to see the posters and they've still got to understand it, and their patients are not at their best at this time. So, I do see that. I think it's a tricky thing. We also we follow patients up as well at about the 90 to 180 days. So we do actually contact them as well, and they actually get a phone call from someone. So we are lucky in that way that we are able to speak to the patients, and I guess perhaps some of these issues may be coming up in the phone calls. Oh gosh, I didn't know that I was in this registry. I mean, sometimes they also say, gosh, I didn't know I had a stroke. That's
yes.
I think, it'd be naive to think that that just didn't happen. And look, I think in those instances, we just explain to the patients what it's about, to say you can absolutely opt out now as well. So they can opt out at so many levels. And I guess it's just something that, we have to hope that the greater good outweighs the patients who don't see the data, and who are unhappy. But we try to explain to them that completely understand you can opt out now.
Yeah.
In terms of you raise a very, very important point about further research, and I think that's a whole different ball game. And we cover that off in our follow-up data, because we have a box, which I'm super happy that we have, because I thought we really need to ask patients permission. And in the survey where we ask for their follow-up data about their health quality of life outcomes, there's another box that says, would you be prepared? Can we use your data for other people to contact you about other research projects? And they can either say yes or no to that. And that has been such an invaluable tool for particularly studies and trials in the community where it's really hard to find patients. How do you find them? How do you approach them? You're not going to get everyone. If you try to get them, those that come into a rehab setting, it's only those that get to rehab. And so that's been an incredible tool and an incredible win for researchers wanting to get to patients in the community. And most people tick the yes box. So no one from OSCA should be surprised that they get approached by other people if they have ticked that yes box. I love that we ask them again about it. And obviously they can opt off at each time.
Yeah, no, it's a bit of an ethical dilemma, and I don't think we'll ever really, because collecting this sort of data is so important. It's for the greater good, and it's usually a very, very small percentage of people that actually have an issue, but it's the very, very small percentage that can be, destroy a reputation, or and we have to balance that out. We don't want to end up in front of the Daily Telly as an institution. So that's that it's just a very small percentage do actually follow up with us and have an issue, and we need to manage that. But again, at the front end of it all, it's about appropriately informing people what's going to happen to their data. But it's a tricky one. But thank you, Sandy. I really appreciate that.
Any more questions? There's no more in the chat. So if we're ready, Suchit, can I hand over to you? Thank you.
Great, thanks, Maridulu. I'll just share this. Beautiful. I'm assuming you all can
looks good.
see that. Awesome. Well, thank you all, and thank you, Maridulu, for inviting me to talk to you today about the framework for Australian Clinical Quality Registries. And I'm going to delve into a little bit of the framework as well as the national context, and then possibly how does it apply to you in your everyday work, whether it be in a clinical setting or in your hat as an ATREC ethics committee member. So just before I delve into the framework itself, I just wanted to talk about the national context. So the framework for Australian Clinical Quality Registries doesn't operate in a silo of itself. There is a lot of other good work happening across sister agencies, sister national agencies, state and territory government departments, as well as local health districts, and as well as a Department of Health and as a government as a whole. Some of them I've listed there, but in particular, some of the strategies I want to bring your attention to is the national strategy for maximising the value of Australian clinical quality outcomes data. So that's by the Department of Health, and that's their strategy for clinical quality registries up to 2030. My poor colleagues at the department released this sort of around COVID, and so for the first 2 years they've kind of been on the back foot with it, but they're now coming back on track with the strategy. But priorities areas 11 to 15 really outline the actions and the strategies for the Commission to work on, particularly regarding for registries that are still operating within a research framework. That there's work to be undertaken around streamlining site governance, patient consent, and the ethics process itself. Recognition as a national quality assurance activity for particular clinical quality registries, and supporting the Commission and the Australian Institute of Health and Welfare to revise national health information agreements so that it makes it easier to capture and collect national clinical quality outcomes data directly from its source. As well as in working with the Australian Digital Health Agency on their National Healthcare Interoperability Plan and their strategy. Again, all of these national strategies work in partnership with each other. We talk on a consistent basis to make sure that all the work is aligned, and particularly for clinical quality registries, which is getting a lot more traction lately. So in regards to the national framework that the Commission has developed, before we started to review and develop the second edition for the national framework, we actually undertook a review of the evidence regarding clinical quality registries best practice, as well as a review of the legislation and regulations related to clinical quality registries. And all of this is available on the Commission's website. But what we did find through the initial review of information was that clinical quality registries vary in their capability and capacity to achieve their objectives, and that's Sandy outlined a few around funding, technology constraints. There's still a lot of data silos, and for some registries, economies of scale have been difficult to achieve. But again, as through Sandy's presentation, you saw there are registries, when they operate at a mature level, do have the opportunity to provide that economies of scale. And of course, security and privacy is still a concern of CQR operators, as well as state and territory governments and CQR operators alike. So what does the best practice actually look like? So a best practice for a clinical quality registry is one that has access to health data at its source and applies an appropriate interoperability framework. So being able to pull data from various EMRs and feeding it into a national database that has appropriate security and privacy controls in place already. And of course has appropriate governance arrangements that bring data custodians, clinical stakeholders, management, technical administrative support, as well as patients to the table, and puts in place processes for quality operational improvement over time, and as well as processes for outlier management. And this diagram we use in the framework itself, as well as on our website, and it really just summarizes what we are aiming to achieve with the national framework. It is to really have that cycle of data being turned into knowledge and then wisdom and then back into the health record system. So it's part of a learning health system. And then so the framework itself, the revision of the framework, it offers guidance for CQR operators and health services that are moving towards integrating CQRs into quality improvement cycles. OSCA's a great example of that. And thus the focus of the framework in second edition, the revision that we're currently undergoing, is on nationally prioritized conditions and procedures. So that's where there are serious consequences to the patient and associated with poor quality of care. Unwanted variation, as Sandy mentioned, 1.28, an evidence-based sequence of care that's evidence-based, and that there is already a need to capture at a national level this evidence-based care. There's for registries that have a significant cost burden associated with the condition or procedure or device that they're capturing information for. And of course that there is also, it is an emerging area of priority, whether it be from a government priority area or from the clinical domain. Some of you might be aware that the Commission led a national public consultation of the second edition of the framework early in the beginning of the year, and these are the overarching chapters that were consulted on, and I'll go through the findings of the consultation shortly. But I just want to point out that one of the biggest pieces of feedback that we did receive was that the logical architecture and design and security compliance were too dense, and that's why they've been grayed out in this slide, just to reflect that they won't feature in the main framework itself, but will be there as appendixes to the main document to offer the guidance for people that might need it. So we conducted the consultation from Jan to March through an online survey. We then undertook targeted consultations from March to April, and we had a really good representation across the board from health service executives to CQR operators to academics as well. And then we also received written submissions from special interest groups, from universities and other governmental organizations. So what did we find? That is, through the consultation process, that there was support for the intention and aspirations of the framework. It does set the bar quite high, and acknowledges that there is still challenges around the national health infrastructure, data standards, but majority of the participants supported the move from a research paradigm into a quality improvement paradigm to really drive quality improvement at a local level. They did obviously acknowledge that it is still a future-focused approach, that it is valuable and inevitable. It will get to that point, but there's still some time till we get to that aim and intention of the strategy as well as the framework. That there was still a need for meaningful consumer engagement built into clinical quality registries, whether that be in the design or the outcome and reporting of data, that there's still a large need for that. There was also a need to provide clear definitions on and clarity around what constitutes as a national clinical quality registry, a register, an audit, and as well as what is the meaning of data custodian, what does data ownership mean, as well as the different levels of maturity that registries also find themselves in. And as Sandy mentioned, the importance of engaging senior decision makers, including healthcare chief executives and LHD executives, as well as medical colleagues and clinical societies, was key for success for a national clinical quality registries. And then we also, of course, heard that the document itself needed a bit of a rewrite, which is what we are currently undertaking at the moment to make it a little bit more user-friendly as well. And lastly, that there was some suggested strategies to support the implementation of the framework. So what are we working on now? So some of the proposed recommendations, so that we are continuing to revise the framework, and that's going to be providing the national strategic and operating principles and best practice guidance for governance, data management, privacy, and safety and quality reporting for national clinical quality registries. That there should be in the future providing a quality standard for clinical quality registry operators to support ongoing improvement in collection, reporting, and then actioning national clinical quality outcomes information. That we as a commission develop a self-assessment in the first 12 to 18 months before we go full board into a setting of standards and a corresponding accreditation scheme. So that's something that we're investigating now. There should be mandatory public reporting for national clinical quality registries as definitely a value add for healthcare providers and funders, as well as the community at large. And for registries to be able to pull information and data from its source, that there also needs to be a need to integrate the healthcare identifier into routinely clinical collections, as well as the registry itself. So what are our next steps? So we're currently revising the framework at the moment with our expert advisory group, which we're nearly through our workshops that Sandy's excellently chairing, and hoping to get a revised version back to our advisory group at the beginning of December before Christmas, with a view to take it to our governance committees in March, then to seek final board endorsement, the Commission's board, in June 2024, with a release of the framework in July 2024. And I purposely put this quote in here, and this was one from the consultations that we conducted at the beginning of the year, and it really does sum it up for me that the framework is best practice. It is visionary. It does set the bar quite high, but we do need to start somewhere, and that we do need to provide the guidance for national clinical quality registries who are mature, who can meet the requirements of the framework, but as well as give guidance to other registries that are up and coming, that need more guidance, and use it as a bit of essentially that self-assessment that we will be developing in the future, to see where their gaps are and then move towards that high level of maturity. And one of the other pieces of feedback that we heard at the consultation was that the framework needs to still provide a little bit more guidance on the overlaps between quality improvement and the research paradigm, and that we will be really taking the guidance from the HMRC and the guidance that they put out in 2014, the ethical consideration and quality assurance and evaluation activities. Even though it's a 2014 document, vast majority of its principles are sound. And we even heard at the Australian annual scientific meeting for clinical quality registries recently that a few registries adopted the framework and then put it through its paces at a local site assessment approval process, as well as a and HREC approval, and they really demonstrated that by adhering to the framework and adopting the framework, that the HREC approval process was seamless and quite quick as well. And if I could just quickly delve into the department, so I'm also presenting on behalf of the Department of Health and Aged Care. They're a close partner in developing the framework. And this was a pilot project that they funded as part of the national strategy under Priority 11 with the Monash School of Public Health. And they focused the SCRAP project, as it's known, was developed and implemented for CQI implementation at local health services via a quality assurance approach rather than the current research governance office. And they really, the aim of the pilot was to assess the model's effectiveness and potential to inform a new national approach. So they conducted a literature review first and worked with the Monash University team to further engage organizations to participate over a 12-month period. And then they determined the enabling the structures and processes that they will need at a local level and how that project would operate at the LHD level. So stage 2 of that pilot included the engaging 4 clinical quality registries and 6 health services across multiple jurisdictions and the private and public sector alike. And as part of the overall leadership and governance of the SCRAP project, the commission sat on it as an advisory member. And we really tried to target the health service executives, health service clinical governance teams, the research governance officers, as well as the clinical quality registries alike, to start building the rapport and the relationship between these 3 separate parts of an organization normally. So the project has been summed up. It's being currently, there's a final report being provided with recommendations from the pilot to the Department of Health for consideration, and we're hoping to see how we could use these recommendations and insights from the pilot to then inform a self-assessment as well as then a potential accreditation scheme for clinical quality registries. And on that, I will end it there and stop sharing my screen.
Thank you, Suchit. So obviously this is now open again to questions or even comments. I think we're hearing about some fantastic changes that are taking place in the whole ethics review space. This is one of many, as many of you would know, about what's being done, particularly at the national level, and then how we're hearing today about how that will potentially flow through into ethics review at the level of the organisation. So this is a little bit forward thinking. I think we're thinking not so much right now about what's happening right now, but what's going to happen in the future. Does anybody have any questions for Sandy and Suchit about what they're seeing now, how they think what's to come might impact on the ethics reviews being done at within your committees? It's very quiet. I'm not going to drag it out. If people,
sorry, I put my hand up. Sorry. Yes. Thank you. I'm from the SHN Governance Office, and I just want to check with that pilot study, and apologies if I missed it, because again, from a governance perspective, we'd love to support these registries more. We just get tied up in the governance requirements for these data sort of registries, and making sure patient privacy, and also when the data is being transferred, who's it being transferred to, is covered all accordingly. In that pilot project, how did you find site governance were responding to this sort of potential change? Because I do agree it's a little bit sort of not convoluted is not the right word, but it's a little messy, and any sort of streamlining attempt would be very happy for, but it's just a bit difficult to see how this could be streamlined in that way. I just your thoughts on that, if that could be possible.
Sorry, William, just so that I've understood the question properly, you're asking about the potential of streamlining of sort of the privacy and security arrangements of registries?
Yeah, so because what we find with registries, which really slows the whole approval process down, is the agreements necessary to facilitate the transfer of this data correctly. And especially for these registries, people can come on later. We really need to have a robust system in place to ensure that we know that when researchers apply for access to this registry, that all the sort of proper governance procedures are in place. And we do find that a lot of researchers get frustrated with that process, and we understand why, but it's sort of that sort of rock and a hard place where we need these agreements and this sort of scaffolding to be in place. But researchers obviously want ease access to this data. So it's how to find that middle ground. I was wondering if that had that been encountered in that pilot project.
Yeah, no, thanks. Well, that's a really, really good question. I think as Marilyn mentioned, we're moving towards that because it is still a problem and a pain. So it was separate to the scrap project, so I'll put that aside for a while, and potentially talk to you about some work that I'm hoping to get a lot more information on recently, where two registries use the framework and all of its documentation regarding security and privacy compliance, and essentially provided an HREC committee with the assurance that they have followed the Commission's guidance on security and privacy, and that they have, to the best of their ability, tried to met the requirements. I should say, not tried to, met the requirements for privacy and security as per the Australian standards. So that's one way of doing it. The other is also that the AHW and the Digital Health Agency are also developing data standards as well as interoperability standards, or a framework at least, to provide guidance to for the technical side of things, to make sure that the way that it is going to be specified from them is the safest and securest way. So if a researcher or a project demonstrates their adherence to those national standards, I think that should make your life a little bit easier. But again, in the future, not at this moment in time.
That's perfect. That sounds something sort of standardized along that way would go, as you've just said, a great way to streamlining it on our end, especially with different institutions and different practices in regards to data transfer and that sort of thing. So thank you for your answer.
Marilee, is it okay if I just jump in and talk to that as well?
Yes, indeed. Thank you.
Okay, sorry, Monique. William, I just love your question, because obviously I'm a researcher and I do multi-site studies, and I'm trying to say to all of my teams, we've got to stop doing single site research on one ward in one hospital. We're never going to get that data published. We're never getting funding for it. We need to have multi-site, and I'm doing a big trial that's got 45 Australian sites and 8 New Zealand sites. And now each of the governance officers is saying, oh, you need to have a research contract. And I've got this huge backlog in the university reviewing the contracts. If there's anything that we can do to review that, and obviously we have to, we want patient data to be safe. That's absolutely crucial. But I would love it if someone could think up a sort of ethically approved way that didn't need all these contracts, because it's slowed down research. I won't be able to get nurses to do multi-site research anymore. It's hugely expensive too, and it's really going to be detrimental, I think, to multi-site collaborative research. The cost and the time, because you're just eating into the salary of the researcher who's sitting there waiting for all these contracts. Like, their salary will be blown out and gone before you even get the trial started. So I would love it if we could collectively fix that, get some alternative.
So just quickly on that, just because I've heard it referenced a couple of times now. Sorry, Pamela, if you want to go jump in.
Oh, no, you go ahead, William, and I might follow up. You might be saying what I'm going to say.
Oh, yeah. All I was going to say is that I hear, like you've said, an ethics response. And just to clarify, even if you went through ethics, and because ethics aren't really concerned with the sort of data security aspect, well, they are concerned from an ethical point of view, but even if ethics said that's okay, it's still questioning if governance would accept it, because we do look at things that ethics doesn't consider. So I think that the separation of those two concepts really needs to be put forward.
Apologies.
When we try,
yeah.
So no, just
that was clumsy of me. I did mean governance. Apologies.
No, oh, sorry. Okay, no,
Very
that's fine,
poor.
because I think a lot of researchers do make that mistake, and it's very understandable. We're very
No, I actually knew better. I did know better.
Okay.
So sorry.
Oh, good then. Yeah, but sorry. Okay, that's fine. Sorry, I just want to make that clear. Apologies.
Yeah, no, so noted. Thanks, William. So you ethics and governance very separate. The governance side of things, would require some looking at agreements, etc. How, just out of interest, how many sites in New South Wales, Sandy?
45 in Australia.
Right.
45.
In Australia, how many in New South Wales?
I don't have the numbers to hand. I wouldn't want to make it up. Sorry.
20, say 20, 30?
Yeah, probably. No, at least 15 to 20.
Yeah, so there are some initiatives currently at foot, led by OHMR, New South Wales Health, to have a very, very streamlined process for RGO review and approval of studies, particularly like this. Will, that's the effort that Jackie Nee's leading up at the moment, and this study could be a very good case study for them, just to sort of streamline. It doesn't, her approach is, I mean, it's very much in its infancy, but this could be a case study. And if you wanted to maybe talk to me, and we could go to her together with it.
Oh, that's so lovely. Thank you, Pamela.
That's
I don't know,
great idea,
William.
Pamela.
I don't know, William, if you would agree here, but this would be a perfect example of where we could sort of say, yeah, look, there are 30 sites involved in New South Wales. Unfortunately, because we're so, it dates back to when we all had different widths of railway track across Australia. I can't speak for the other states, but can we just maybe have an offline?
I'd love to do that. Thank you so much.
Conversation, and maybe I can then, I can't promise anything, but at least
just even someone to listen.
Yeah, exactly. Okay, thanks, Sandy. No worries.
Monique, did you want to say something?
Yeah, thank you. I realize we're almost out of time, but I'm working the ethics space, and I guess I just wanted to sort of touch on the fact that I'm of the view that a clinical quality registry doesn't always necessarily require ethics review. I'm not saying it doesn't require some sort of institutional oversight, but we also sort of use the NHMRC guidelines that Suchit mentioned, which basically indicate that unless the study has some sort of ethical triggers, then it may not necessarily need to undergo an ethics review process. But it is a tricky space. It sits in that QA QI sort of grey area, I think, where it can be hard to know when something is research. Like, obviously, if something's going to end up being used for research purposes, that's different. But if it's just going to be used to inform improvement in the quality of healthcare being delivered, then that's something that needs to be considered. That often does end up sitting with a research office or an ethics committee to make that call. But yeah, I guess I just wanted to raise that. I don't know. Unfortunately, I don't think we have a consistent approach, but yeah, I just wanted to raise that.
No, Monique, thank you. That was it is really tricky, and there isn't consistency at the moment. The only thing I would offer is that I think through the consultation that we've identified, we probably need to work with NHMRC a little bit more closely on the revision of the framework and provide more guidance for registries. And I would also say probably for those national clinical quality registries, such as Oscar, as Sandy outlined, they've got an internal policy on how does the organisation, in a way, the institution really support the use of research and the secondary use of data. So they've got a policy, they've got structure, they've got governance. And for those national clinical quality registries that most often than not will use that data for research as well as quality improvement, but also for research, that they most likely will be coming through HREC offices. The others, the much more smaller, maybe bespoke registries that are very specific to quality improvement, whether it be for, like, say, I was going to say bariatric, but that's a very bad example. I can't think of one at the moment, but the ones that are sort of time limited, that are going to be targeted, low risk, don't need to. But a risk assessment would be good. Then it at least gives you that guidance to go where to go.
I guess as just Monique, a fantastic point. The tricky stuff is that you don't really know what you always want to do with it down the track. And a really good example is COVID. So we sometimes publish data from the registry that it's not around a research project. It's just like, let's tell you about the natural history about what's going on here. And we were able to put a submission into the Victorian government, which was really helpful, that showed that in COVID, patients weren't receiving evidence-based stroke care because often the stroke wards were taken over, the processes were all up in the air, and they didn't do as well. And they really, the care dropped off. And so that ended up being published. And in order to do that, the journals say, oh, have you got HREC review? So, it's almost like, oh, we just go for it once. You only need to get it once from the lead HREC and then keep updating.
Yeah, I understand. Yeah. It's tricky.
Yeah, it's as you say, it's just a bit of a tricky thing.
Yeah. I mean, there is still, just needing to publish isn't necessarily a trigger for ethics review. But yeah, I understand it exists on a continuum. You don't always know when your QA is going to end up being researched. So I think people are on the side of caution in getting that ethics review up front. Yeah, but it's a bit of a tricky area.
Suchit, I noticed you put a link to the one-stop shop in the chat. Do you want to just talk through what?
Yeah, I think there was a bit of conversation around governance and probably single site authorization and that kind of conversation. So I thought I'd just do a quick plug for the work the Commission did on the national consultation for the one-stop shop, which was a contractor piece of work from the department, and that the one-stop shop and National Clinical Trials Front Door really tries to aims to achieve that real tightening of the governance and sort of less trying to reduce the duplication for research across, and particularly for clinical trials across Australia. Just for information, because there's been no announcement of funding yet, so it's still for consideration by the government.
Thank you. Now, when we planned this, we discussed the fact that you may get an early mark today. That I did set an hour and a half for this session, for each of the sessions. But in fact, if there are no more questions, then we might let everybody go and have some lunch before your next meetings.
Sorry, can I just say something? It's Diane Davies here. With the opt-out form, I'm just wondering, is there much education? I've never seen any education for participants or people going, for the opt-out. And I'm just wondering, is there much information for the general public about this opt-out system? I just think it would be better if people knew that it was going on. And I don't think most people realise that there is an opt-out even. Certainly it's not discussed with people who are given a form. And I think most people would miss it.
I'm thinking
Can I speak to that? I mean, I agreed. I think some education around this would be really, really helpful, and particularly building that into your study design, making it really, really clear up front. The information sheet that's given to participants or potential participants is that you're under no obligation to agree to have your data provided, and making it easier for patients to take that option, because there's often a 1-300 number that they have to call. As I said, it's often when they're at home and they've had their treatment and they're flat, and they've got lots of other things going on perhaps. And the last thing is on their mind. So I think better communication, Diane, would really, really be helpful. Because it's always, and we've just had a recent issue that I've addressed around this, And, you know, it is surprising that the opt-out option is tucked away at the back in small print, and it should be up front and center. That, I mean, that's just and I think that would just be helpful. That would be helpful to participants. It would be helpful to us. Real transparency around what it is that you're trying to do. Because I think 99.9% of people don't mind. They see this data being collected for the greater good, but there is a tiny fraction who do mind and feel that their privacy is being breached, and it's actually not being breached, but that's another, you know, question. It's a whole other separate issue, but I do think we have to be careful. And I think transparency and education is great.